old and above, and those who already had underlying health conditions were the ones most affected by the virus. This doesn't necessarily mean that those people are more at risk of contracting the virus. All this means to say is that if ever they were to come in possession of the virus, they would be the ones who would most likely experience more severe complications. As of April 12, the global fatality rate was a 6.1%. As of April 21, the fatality rate has raised to 6.9%. But in countries who have access to better facilities and resources, they tend to have a better prognosis. For example, more people are recovering faster in the US than the Philippines because they have better access to resources and facilities that can help them fight the virus. The virus takes about 2 to 14 days to develop, and symptoms are usually very manageable. But those who may have underlying health conditions or are older, like I mentioned before, may become worse over time, and it might lead to their death. The ones affected with COVID-19 aren't available to execute their activities of daily living or ADL as they normally would be able to. The virus can be spread very easily from person to person, so self-isolation has to be done. And if things worsen for that person, they would have a much harder time breathing or have it worse than like a fever. So, of course, that would affect someone's ADL. For people that are considered mild cases, it usually takes them 2 weeks to recover, and for those that have serious conditions or are in critical condition, it would take them 3 or more weeks. In December 2019, Wuhan, China experienced an outbreak of an unknown virus and disease that they thought was similar to SARS. On March 11, 2020, World Health Organization declared COVID-19 or coronavirus disease as an epidemic. The common coronavirus causes a URTI, and people get infected with one or more of those viruses at some point in their lives. Severe acute respiratory syndrome, coronavirus, or SARS-CoV, most resembles the one we're experiencing now, and that caused an outbreak in 2002. The coronavirus is believed to come from bats and were somehow passed on to civet cats. There was also a type of coronavirus in Saudi Arabia in 2012, and they believed that to come from bats who infected camels. That was referred to as MERS. This new coronavirus strain is believed to also come from the same animal and affected pangolins. In the Philippines, the first reported confirmed case of COVID-19 in the country was on January 30, with a 38-year-old Chinese national. With COVID-19, WHO stated that people that have had contact with those with confirmed cases should be monitored for 14 days, and that the disease is often transmitted through droplets. So when someone sneezes or coughs or even talks, they can transmit the virus to another person. The 6 feet rule was made because it's believed that 6 feet is a safe distance to avoid the transmission. On surfaces, the virus can stay for 24 hours, while in air, it only lasts for 3 hours. The most common symptom of COVID-19 are fever, dry cough, and tiredness. Not a lot of patients experience other symptoms like nasal congestion or pharyngitis. Most people only have mild symptoms and get better without any special treatments, but some cases are asymptomatic, so they didn't show symptoms, but they had the virus. So as of now, there is no vaccine for COVID-19, but some vaccines and drugs are being made and tested through clinical trials. However, they won't be available for at least a year. As of April 1, there were around 800,000 cases reported globally, with a 4.9% death rate. As of April 21, the numbers have raised to 2.5 million cases with a death rate of 6.9%. Of the active cases, there are 95% in mild condition and 3% in serious or critical condition. For the closed cases, which means the cases that have had outcomes already, 80% have recovered or were discharged, and 20% have died. So, for the anatomy and physiology, we will be focusing on the respiratory system. The respiratory system is the organs and body parts that help with breathing. There are two main components, the upper and lower respiratory system. The upper respiratory system has four parts, the nasal cavity, the sinuses, the pharynx, and the larynx. The nasal cavity has a mucus lining which traps dust, and the cilia, or the little hairs, help move the particles so they can be blown or sneezed out. The sinuses are air-filled spaces that help make the skull lighter. The pharynx lets food and air get to where they need to go, and the larynx is important for humans to be able to speak. All these are located outside the chest cavity. The lower respiratory system also has four parts: the trachea, the lungs, the bronchi, and the diaphragm. These parts are inside the chest cavity. The trachea is the main airway to the lungs and is just below the larynx. The lungs are one of the largest organs in the body when put together, and they are responsible for providing the capillaries with oxygen and getting rid of the carbon dioxide in us by exhaling. The bronchi has two branches, one for each lung, and they create passageways so that air can get to the lungs. Lastly, the diaphragm, which is the main muscle that helps get air into the lungs by contracting and relaxing. In the lungs, there are little air sacs called alveoli. They're the ones responsible for gas exchange of oxygen and carbon dioxide. So when a person breathes, the air they breathe goes through their mouth or their nose and goes to the back of the throat and then into the windpipe. Then that air gets pushed into the bronchial tubes, and those tubes go through the lungs and split into smaller air passages called bronchioles. At the end of the bronchioles are where the alveoli are found, and each person has about 600 million alveoli. The alveoli have little blood vessels surrounding them called capillaries, and they carry oxygen into the blood. When a person has COVID-19, they experience shortness of breath as the most common symptom. This is because the lungs and air passages become infected, and it damages the respiratory tree. The lining of the respiratory tree becomes inflamed once the infection reaches there, and that makes it harder for the air to go through and for the gas exchange to happen, so as a result, the person has a difficult time breathing. In worse cases, the infection could reach the alveoli and make the wall of the alveoli thicker, causing inflammation. That inflammation would lead to excess production of fluid, and that fluid would then make its way into the lungs and could cause pneumonia.
Hello, my name is Irol Lozada, and I will be discussing the coronavirus disease or COVID-19 pathophysiology. To start off, the COVID-19 came from a type of virus known as the coronavirus, which can be transmitted from person to person through respiratory droplets or fecal-oral route. The risk factors of the disease are people that have unhygienic practices, exposure to places with recent outbreaks, ages 16 and above, people with comorbidities, physical contact of 3 to 6 feet with possibly infected person. The virus can also stay on the surface for 24 hours and in the air for 3 hours, although it cannot be confirmed if the virus is still strong enough to infect a person. So the etiology of the virus is called the coronavirus, which is suspected to have come from animals or species of pangolin, which are then transferred toward bats, which then later on transferred to infect humans. So the reservoir is the human respiratory system, portal of exit is the respiratory tract and the feces, and for the mode of transmission, it's droplet spread and the fecal-oral route, portal of entry, the respiratory tract, and of course the susceptible host is the compromised humans. So, the virus travels towards the respiratory system from the mouth or nose to the pharynx, then larynx, bronchi, bronchioles, and then eventually reach the alveoli. An alveoli has two kinds of cells. The virus targets the specific epithelial cells in the alveoli to infect specifically the type 2 pneumocyte called goblates. The goblate's function is to produce surfactant, which these surfactants decrease the surface tension to prevent alveolar collapse, and also the cells in which the virus will attach to it and proliferate. So the mechanism of the virus infection inside the cell is like this. A virus inside has a positive single-stranded RNA virus. So first, the virus has an S protein, or also called as the spike proteins. This is what it is using to enter the cell, which binds with the ACE2, or the angiotensin converting enzyme, by the surface proteins with the spikes. So these spikes are like the keys to the virus to enter the cell of the ACE2, and is needed for the virus to enter the cell through endocytosis with binding of the S protein to the type 2 ACE enzyme. So after that, the virus will then undergo a process called translation, which tells the ribosome to produce more of itself, or produce virus parts, and also the Golgi apparatus to produce virus parts, which will then eventually make into a full-blown virus and exit the cell through exocytosis. Alveolar macrophages can detect the virus using a special receptor called toll-like receptor, or TLRs. It can engulf a part of the virus particle to present to the system, which will then help the system to detect that there is an infection happen, which can help the system adapt to an immune response and make antigens to help fight off against the virus. Alveolar macrophages detect cell injury via damage-associated molecular patterns from the alveolar cell. They also respond to the cytokines released by the injured alveolar cells, causing the macrophage to secrete cytokines such as TNF-alpha, interleukin-1, interleukin-6, interleukin-8, and as well as chemokines. This will then go to the bloodstream, which causes endothelial cells to dilate, increasing capillary permeability, causing the endothelial cell to contract. Then the inflammatory process occurs with the lung parenchyma, and will eventually, all of these cytokines will stimulate the cough reflex of nerve endings, which will usually how the symptoms show as dry cough. So as the cytokines go into the blood vessel, they can trigger vasodilation and increase capillary permeability. Furthermore, the TNF, or the tumor necrotic factor alpha, and the interleukin-1 are pro-inflammatory cytokines and cause increase in vascular permeability and increase in expression of adhesion molecules. This allows recruitment of more immune cells, including neutrophils and monocytes, which they will bind into these adhesion proteins and enter the site of injury. Interleukin-8 will recruit neutrophils and other chemokines, which will attract monocytes and increase the vascular permeability, which causes leakage of fluids into the interstitium wall and inside the alveoli, which will eventually result into alveolar edema, which can decrease the surfactant, and with the increased pressure on the surface of it, it can cause the alveoli to collapse and causing dyspnea and or impaired oxygenation, which will lead into hypoxemia, which means this reduces the lung ability to respirate, and gas exchange, which will lead to difficulty of breathing, and decreased oxygen levels in blood will stimulate chemoreceptor in the aortic arc and carotid as well as in the brain to stimulate the cardiopulmonary center in the brain to tell the lung to breathe more, therefore increasing the respiratory rate, or tachypnea, in order to increase the oxygen levels in the blood. Also tell the heart to pump faster, which result into tachycardia to alleviate the person, and usually use of accessory muscles to help aid in the difficulty of breathing. And all of this condition can progress to a condition called acute respiratory distress syndrome. Another thing is that inflammatory mediators also bring a lot of neutrophil, which this neutrophil will go inside the inflammatory site and try to destroy the virus by releasing an reactive oxygen species called proteases. So here's the diagram. However, this will not only destroy the virus but also other cells in the alveoli. It will destroy the type 1 pneumocyte, which is the cell for gas exchange, and also damage the type 2 pneumocyte, which is in charge again for the decrease in surfactant production, which will later have a decreased surfactant and then will lead to increase in surface tension, which would lead to alveolar collapse. As the cells begin to be destroyed, they will start at the center of the alveolus. So in the center of the alveolus, there will be a fluid and debris deposition, which would lead to alveolar collapse again, and there will be a consolidation of fluids and debris which would then alter the gas exchange, resulting to hypoxemia. This is also where the productive cough happens because of the consolidation of fluids inside the alveoli, and the body tries to expel the fluids through the cough reflex. So, the decrease in oxygen will stimulate the chemoreceptor, which can trigger the sympathetic nervous system, resulting to increase of heart rate and respiratory rate. If the consolidation is degraded, the body's response to is to cough it. Therefore, there will be an productive cough. So as you can see here, if the consolidation is progresses into worst scenario, it can produce a productive cough symptom. So the inflammation of lung tissue would also lead into increased capillary permeability, which to then to alveolar edema, causing alveolar collapse that further increase the problem of difficulty breathing. On the other hand, alveolar edema can create accumulation of fluids later turned into sputum, and that is sometimes expelled through the system by the system through the cough reflex. It could also progress towards pneumonia, which causes pulmonary inflammation and decrease the membrane integrity, causing bacteria to reach the lungs, triggering a response to the immune system releasing cytokines, in which is compromised lung would lead to translocation of both bacteria and cytokines, reaching the bloodstream, and systemic inflammatory response, which could lead into a condition known as sepsis. So here, basically, during a lung inflammation, systemic inflammatory response can happen, and the increased capillary permeability will allow the bacteria and the blood and other fluid to leak into the interstitial places. And with this, your normal flora or the normal bacteria inside your body will reach the parts of your body that is not supposed to reach, such as the bacteria inside your gastrointestinal system reaching your lungs, your respiratory system, which can be bad, which will lead into sepsis, eventually leading to septic shock and then death. This also decreases the blood volume, which in return which would cause vasodilation, wherein it decreases peripheral resistance, decreases tissue perfusion, and then reach a multi-system failure. The multi-system failure will show body weakness due to lack of proper body functions and cyanosis due to poor cardiac output. It also specifically affect the kidneys, liver, and gastrointestinal system. So first, in the kidney, if it keeps, it would have an increased production of blood urea nitrogen and creatinine, which would later cause the kidney damage if it keeps producing it due to overwork. It also affects the liver, which would increase its liver enzyme, causing liver damage and increase in AST, ALT, and bilirubin, which then release acute phase proteins such as CRP, fibrinogen, and interleukin 6 to help aid in the inflammation, but overwork of the liver can cause liver damage. Then in the gastrointestinal system, if in rare occasions the infection is progressing into a bad scenario, the virus can release toxins to irritate the enterocytes or the receptors of the gastrointestinal system, which can then lead to diarrhea, and if in worst case scenarios, it can lead to dehydration because Virus toxins can impair the function of the gastrointestinal system. So here, when the interleukin 1 and interleukin 6 enters the bloodstream, it also goes towards the CNS. So in the CNS, it specifically goes toward the hypothalamus to trigger a cardiopulmonary response and to find a specific prostaglandin, which is called the PGE2, that will reset the thermostats of the body. And this would later in turn affect the normal thermal regulation of the body, increasing the body temperature, resulting to fever, which is the most common symptom of COVID-19, which can result to chills as the body adapts to room temperature, and diaphoresis to cope with the internal temperature changes of the body to cool it off as efficiently as it can. So that is my part for the COVID-19 pathophysiology. Thank you very much.
Hello everyone, I am Alvin Macalintal and I will be doing the possible physical assessment findings and the diagnostic and test. And then later I will also close with recommendations and summary. Our probable patient will most likely have these following signs and symptoms. Difficulty of breathing, we have fatigue, loss of appetite, insomnia, dyschezia, persistent in pain or pressure in the chest. You got bluish lips and face. There are ones that are not common, but they can occur. For example, the two are insomnia and dyschezia. Moving on to our patient, the probable patient has a rate of 26 breaths per minute, and it is diminished breath sounds from the right lung, and it was heard upon auscultation. And they have a positive result from bronchophony, egophony, and a whispered pictoriloquy. There is a presence of spasms and jerks, and the patient has a CTT or chest thoracostomy tube inserted there. And the CT scan shows that the pneumothorax has a slight or mediastinal shift to the left. There's like an opacity in the right lower lobe. Also, a decreased tactile phlegmitis and slight nasal flaring. And lastly, some other possible findings could be fever, dry cough, decreased appetite, and myalgia. And I will continue on with the topic of diagnostic and test findings. Before going into the test and how COVID-19 is diagnosed, what needs to be first addressed is at the time of the research, the CDC stated that there is no concrete defined serology test because the CDC did not have the basic parameters. At the moment, there is one option to diagnose COVID-19, and this is the RT-PCR test. It stands for Real-Time Reverse Transcription Polymerase Chain Reaction, and this was originally developed for the SARS virus. The RT-PCR test is illustrated from this video. The goal of this test is to make complementary DNA from RNA, and this requires RNA, the reverse transcriptase enzyme, a primer which begins the sequence, and DNTPs, which are the nucleotides. First, the RNA is incubated so that it is denatured into its secondary structure. Then it is cooled so that the primer can attach to the RNA. Then the enzyme reverse transcriptase can begin and attach all the DNTPs or the nucleotides to make the complementary DNA. This procedure, it takes a cotton swab inserted through the nose to collect the specimens in the nasopharynx or oropharyngeal area. For the people who are intubated, then the specimen should be collected through a lower respiratory tract aspirate or a bronchoalveolar lavage. The results that lead to a positive conclusion is that novel 1 and novel 2 of the SARS-CoV-2 are detected. So if the patient is negative, then according to the FDA, they need to have a management decision that combines the results and the assessment from the patient history, physical assessment, and epidemiology reports to make the conclusion because sometimes people can have a false negative, and the accuracy of the testing kit is not always 100%. Medical management. One use of medical management is oxygen therapy. This is used to correct and prevent hypoxemia and to improve survival. Before administering the therapy, the equipment must first be checked if it is working. Also, the patient's airway must be assessed, and then to assist the patient into a proper position, such as tilting the head or lifting the chin in order for them to have or optimize breathing. Lastly, at the end of the therapy, the findings are to be documented. The next medical management is the NIPPV, and it stands for the Nasal Intermittent Positive Pressure Ventilation. This device is a life-saving intervention of someone with acute respiratory failure, and it provides treatment without using intubation that can be inserted into your endocardial region. The pressure assists with opening up the airway, and what needs to be assessed is the equipment to see if it's working properly, that the settings are appropriate to the care of the patient. Next, the vital signs such as HR, RR, BP, O2 saturation, and hourly to be assessed the lung sound. And lastly, the patient's level of consciousness. Preventive management. For preventive management, the best measures are categorized into these four parts. First one is to observe strict hygiene. Second is to observe thorough hand washing. Third is social distancing. And lastly, it's to know the standard protocol for health care. For the first one, in observing proper hygiene, it is important to know that when one sneezes or coughs, they need to blow it into a tissue, not into their hands or their mouth. After that, they need to dispose of the tissue immediately so that infection will not spread. Next, out of precautionary measures, there should be washing of the hands after coughing, sneezing, using the bathroom, or even before prepping for a meal. The minimum time limit of washing hands is 20 seconds, and it is way better to wash hands with soap than just applying alcohol because it is learned from biochemistry that soap has polar and nonpolar properties that can attach to the bacteria and the viruses so that the water can flush it out. But if the option is not available, it is recommended that a minimum of 60% rubbing alcohol is used as a disinfectant. Third, according to social distancing measures, it is important to limit leaving the house, but if that cannot be avoided, it is important to limit using public transits or to be in close proximity of people. This is because that since infection can spread through droplets, then it is safe to assume that where more people are, then the higher the chance the infection has spread within the area. So it is important that whatever a person touches, then they should not touch their face and make sure to routinely wash their hands. Lastly, for the healthcare measures, if a person is contaminated with COVID-19, then they are to always wear a face mask. But if a face mask is not available and they're having trouble with breathing, then their caretaker needs to wear the mask. Also, if signs and symptoms of COVID appears, then they need to notify the physician immediately prior to receiving medical attention so that the hospital, the healthcare clinic can have time to prepare their instruments and provide protocol so that infection won't spread in the healthcare facility.
Hello, good day everyone. My name is Cumi Ferry and I will be discussing our NCP. So hopefully you'll listen to me until the end, okay? So according to a study of WHO, 31% to 40% of COVID patients have a symptoms of difficulty of breathing. So that is our first problem. So as you can see, we don't have patients. So even though we don't have patient, all of our datas are based from real actual patient. We have searched it. You can link or you can see it in our reference. So first, let's discuss the subjective data. So our subjective data is the patient verbalizes, I feel suffocated and a tingling sensation in my lips, and I had a hard time breathing this past few days, and due to my congested nose and dry cough, it is hard for me to breathe. So as you can see, the patient is having difficulty of breathing. Even I am having difficulty of breathing. And for our objective cues, the patient RR is 30, the patient HR is 120, the oxygen saturation is 91%, which is should be 95 to 100%. Patient is also positive for dry cough, positive for clear and fast adventitious sound when the patient is breathing. The patient is positive for use of accessory muscles and nasal flaring. The patient is also positive for body weakness, and the patient is positive for cyanotic. So, diagnostic results of the patient shows that the ABG is respiratory alkalosis and uncompensated, and the pH level is 7.48, which is higher. It should be until 7.45. Also, the partial pressure of the carbon dioxide is 30 and the bicarbonate is 22. The RBC is 0.625 and the WBC is 4.7. And the let me clarify something about the WBC here. One study in Wuhan, China said that the patient WBC result shows that should be within the normal, so it is not increased or decreased, but the neutrophils is less than 0.001 and the platelets is 168 times 103, which should be, if the patient is female, it should be 157 and 371,000 per microliter of blood, and if the patient is male, it should be 35,000 and 317,000 per microliter of blood. And the chest x-ray also of the patient showed small and large patchy shadows with intensive density in both lungs. And the patient is of course positive to COVID tests such as SARS-CoV-2 N1 and N2 detect in the RT-PCR test, LRT expectorated sputum, and endotracheal aspirate. For our nursing diagnosis, ineffective airway clearance related to increased secretion production secondary to viral infection as evidenced by a positive COVID test, SARS-CoV-2 N1 and N2 detect in RT-PCR test, LRT expectorated sputum, and endotracheal aspirate, and signs and symptoms of dry cough and nasal congestion. For rationale, the alveolar macrophages can detect the cell injury via the associated molecular patterns from the alveolar cells. So, they also respond to the cytokines released by the injured alveolar cells that cause the macrophages to secrete cytokines such as tumor necrosis factor alpha or TNF alpha, interleukin 1, interleukin 6, and interleukin 8, as well as the chemokines. Then, all of this will go back to the bloodstream, which can cause the endothelial cells or the smooth muscle to dilate, thus increasing the capillary permeability by causing those endothelial cells to contract. Then the inflammatory process occurring within the lungs, panerchemia, stimulates nerve ending responsible for the initiation of cough reflex presenting the dry cough, according to Michael et al. 2020. Furthermore, TNF alpha and interleukin 1b are pro-inflammatory cytokines, and this can cause increase in the vascular permeability and increase in expression of adhesion molecules, which allows them to recruit more immune cells, including the neutrophils and monocytes. Then they will bind into these adhesion proteins and enter the injury or the site of the injury. And on the other hand, the interleukin 8 will recruit neutrophils and the other chemokines to attract monocytes, according to Gale 2020. our NOC is respiratory status gas exchange. So our first short-term goal is after 1 hour of continuous collaborative oxygen therapy and nursing intervention, patient's oxygen saturation will increase to 95% from 90%, and the normal value is 95% to 100% because the alveoli of the patient is already damaged and collapsed. Therefore, the gas exchange is also affected. That's why oxygen therapy must be done quickly. And our second short-term goal is after 4 hours of nursing care, the patient's RR will decrease to 20 beats per minute from 30 beats per minute, which is the normal is 12 to 20, and the HR will also decrease to 100 beats per minute from 120 beats per minute, which the normal value is 60 to 100, and there will be a diminished use of accessory muscles and nasal flaring. The skin color will be slightly pinkish, and for our long-term goal is after 2 days of nursing care, continuous oxygen therapy and medication therapy, the patient's oxygen saturation of the patient will be maintained at 98%, and the RR will maintain to 18 beats per minute. The heart rate will maintain to 90 beats per minute, and there will be no accessory muscles and no nasal flaring, and the color of the skin will be pinkish. The ABG result will also be in normal values, meaning the pH level will be within the range of 7.35 to 7.45. The 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 CO2 will be within 35 to 45, and the bicarbonate will be in the range of 22 to 26, and the laboratory values also will give us a normal data, such as RBC being within 3.4 to 9.6 billion cells per liter. WBC will be 3.4 to 96.6 billion cells per liter. The neutrophils will be 3,000 to 7,000 microliter, and the platelet, if the patient is female, will be in the range of 157,000 and 371,000 per microliter of blood. And if the patient is male, he should have a platelet of 75,000 and 317,000 per microliter of blood. And there will be a clear chest X-ray results, and the patient will be negative in all the COVID test. For our NAIC is acid-base management. So the very first nursing intervention, independent intervention, is to assess respiratory rate and depth. Also take down note if the patient is using any accessory muscles, pursed lip breathing, and inability to speak or converse for every hour. Because according to Padula 2009, it is very important to take action when there is an alteration in the pattern of breathing to detect early signs of respiratory compromise. And it is also very useful in evaluating the degree of respiratory distress and chronicity of the disease process. Next is assessed for the skin color, temperature, perform capillary refill, and observe the central versus peripheral cyanosis every 4 hours. Because according again to Padula, lack of oxygen can cause the lips, tongue, and fingers to become darkened with cyanosis. So cyanosis within the mouth is a medical emergency. That's why also assessed and routinely monitored skin and mucous membrane color. Since the patient is positive of cyanotic, because cyanosis could also be a peripheral, which can be noted in the nail beds during the assessment, or central, which is noted around the lips or the earlobes, and this will indicate an advanced hypoxemia. And we don't want that. So therefore, you will also observe the next intervention is observe for the retraction or flaring of nostrils when the nurse interacts with the patient, because these signs signifies an increase in respiratory efforts, and this is always seen in a DOB patient. Next is assess the ABG level of the patient, also according to the facility policy, and take down notes of the pH level, PaCO2 level, bicarbonate level, and because this monitors oxygenation and ventilation status, can determine if it's acidosis or alkalosis. Also, check and note if the PaCO2 is normal, have increased or have decreased, and also the bicarbonate, and check if the base is excessive or deficit. Also note that the PaO2 can determine if there is hypoxia, since the patient have an alveolar collapse. It is possible that the PO2 was decreased. And because of that decreasement, it will stimulate chemotherapies which can active the ANS, thus increasing the HR and RR alter in gas exchange. Next is monitor the level of consciousness and mental status of the patient, as well as if there's any changes. Because hypoxia is a typical manifestation of restlessness and anxiety. Worsening of ABGs accompanied by confusion and somnolence are indicative of brain dysfunction caused by hypoxemia. Next is auscultate the breath sound of the patient, as well as the areas of decreased airflow and adventitious sound, because breath sounds can be weak due to the diminished airflow or consideration areas, and wheezes may indicate the presence of bronchospasm or retained secretions, and scattered moist crackles can point into interstitial fluid or decompensation of the heart. And you can also elevate the head of the bed and assist the client to assume position to his work of breathing, such as semi-Fowler's position, and also include time frames in prone position as tolerated. And encourage the patient also to have a deep, slow, or pursed lip breathing as needed and tolerated by the patient. Because the oxygen supply can be strengthened by upright posture and breathing exercise to avoid obstruction of the airway, dyspnea, and respiratory function. Now you may ask, why proning is also useful other than semi-Fowlers? Well, according to one study of DoD COVID-19 Practice Management Guide -health.mil, in their research, it showed that the support use of prone position to increase the PaO2 level has shown that patients in supine position who are unable to ventilate adequately can benefit from being placed in the prone position to improve their oxygen saturation. Not only the oxygen saturation, but also their pulmonary mechanics and ABG. Also, the anecdotal reports from the Italy have found that the patient with COVID-19 usually respond well to early pronation. And encourage the patient to increase fluid intake to at least 3,000 ml per day within the cardiac tolerance. And also provide a warm or tepid liquids, and recommend intake of fluid in between meals rather than during meals, because hydration helps reduce the viscosity of secretions, which can make it easier to expectorate. And also, bronchospasm can decrease with the use of warm liquids, and during meals, fluid can increase the gastric distension and diaphragm pressure. Next is teach the patient about the diaphragmatic pursed lip breathing. Assess also if there is a use of accessory muscle and monitor for diaphragmatic muscle fatigue or weakness, such as paradoxical motion. Because breathing exercise can help you force out the air bubbles in your lungs. This can also help increase the amount of oxygen in the body and stimulate the diaphragm. And it can also increase the positive pressure generated within the airways and decreases the respiratory rate and increases the tidal volume. And in addition, the breathing of pursed lips enhance alveolar ventilation as calculated by the saturation of carbon dioxide and increase the ventilation of previously ventilated areas. Now, the paradoxical movement of the abdomen, which is the inward versus outward movement during inspiration, is indicative of respiratory muscle fatigue or weakness. Okay, next is encourage and assist patient with abdominal or pursed lip breathing exercise as tolerated. This can provide the patient with some means to cope with and control dyspnea and reduce air trapping. Last is encourage expectoration of sputum and suction when indicated, because thick tenacious and copious secretion in narrow airway are a significant cause of impaired gas exchange. So deep suction can be needed if cough is ineffective for sputuming of secretion. For collaborative care is to monitor laboratory studies such as the CBC cultures, ABG or pulse oximetry, chest x-ray, and pulmonary function test. Because according to Randall and Jensen 2007, this was to identify conditions such as ventilatory failures, monitors disease development or improvement, and to promote pulmonary therapy alteration. And for our evaluation, it is not done due to the coronavirus pandemic. So guys, are you still listening to me? So let's proceed to our second problem. Well, our second problem is elevated body temperature. According to a study of the WHO, fever is 83% to 99%. And you will ask, why is it seconds instead of first, since the percentage is higher? Well, I'm so sorry, guys. I'm so sorry, but this data is a new data, and we already passed our paper before they released this data. But anyways, let's proceed. So for our subjective cues, I don't really feel well right now. I feel lightheaded, and when I suddenly move, I feel hot, as claimed by the patient. So I see the patient is sick, so that's why it's like that. And the objective cues is the patient have a flushed skin with a temperature of 38.9 degrees Celsius, which is higher. It should be around 36.5 degrees to 37.7 degrees, but in some books it says 36.5 to 37.5. Also, the RR is 30 beats per minute, and it should be within 12 to 20. The HR is 120, but it should be 60 to 100. The BP is 90/50, and the patient was also positive for fatigue, chills, warm skin, and diaphoresis. Now, according to the diagnostic test, the WBC is greater than 0.001, which is greater than the normal, and neutrophils is also greater, which is greater than 0.001. And of course, the patient is positive for COVID tests such as serological testing, expectorated sputum, and endotracheal aspirate. So the nursing diagnosis for this problem is Hyperthermia related to inflammatory response secondary to presence of novel coronavirus as evidenced by the temperature of 38.9 Celsius, hot flushed skin, RR of 21 beats per minute, HR of 120 beats per minute, and the WBC count is greater than 0.001, and the patient is positive to coronavirus tests such as LRT, expectorated sputum, endotracheal aspirate, and serological testing. So the rationale behind this is the virus can also attach to the epithelial cells of the respiratory tract, which would then turn into a viremia, where the virus enters the bloodstreams along with the release of interleukin 1 and 6. The body will then detect the presence of the interleukin 1 and 6, and that interleukins will go to the circulatory system, which can go to the hypothalamus, and the hypothalamus will respond and will release a specific prostaglandin such as PGE2 that will reset the thermostats, and this would affect the normal thermal regulation of the body, thus increasing the body temperature, which can result to fever, which is the most common symptoms of COVID-19. This also can result to chills as the body adapts to the room temperature and diaphoresis to cope with the internal temperature change of the body to try to cool off as efficiency as it can, according to Kaselia, Rajnik, Como, Dulebon, and Napoli 2020. So for our NOC is thermoregulation. Our short-term goal is after 4 hours of nursing care, the patient's temperature will decrease from 38.9 to 37.3. The RR will decrease to 25 from 30. The heart rate will decrease also from 100 to 100 from 120. And the patient will experience less fatigability, chills, and perspiration, and the patient's skin will be cool to touch. And for our long-term goal, after 2 days of nursing care, the patient's temperature will maintain to 36.5. The heart rate will maintain also to 18. The RR. The heart rate will decrease to 90 beats per minute, and the patient will not experience fatigability, chills, and perspiration. The patient's skin will be cool to touch. After the care, the laboratory values are within the normal values, such as the WBC will be within 3.4 to 9.6 billion cells per liter. Neutrophils will be 3,000 to 7,000 microliter, and the patient will be negative to any COVID test. So for the NIC is fever treatment. So the first independent intervention is to monitor the patient's temperature. Also note for the degree and the pattern. And take down note if there is chills or profuse diaphoresis present, because according to Donges, Moore, and Morehouse 2012, a temperature of 38.9 Celsius to 41.1 Celsius suggests an acute infection disease process. Also, the fever pattern and cycles can help in the diagnosis, aid in diagnosis, because a prolonged or persistent infection fever curves that last more than 24 hours indicate that pneumococcal pneumonia. Remittent fever that varies just a few degrees in either direction indicates a pulmonary infection, and an irregular curves or fever that return to normal once within 24 hours indicate septic incidence. So next is to monitor the environmental temperature. So limit or add a bedline linens as indicated. It depends to the temperature. Of course, if it's too cold, you should add linens. If it's too hot, you should limit. Well, according to Serrano 2009, the room temperature and linens should be altered to maintain a near body temperature. Next is to provide a tepid sponge bath and avoid using an alcohol, because it is stated by Gulanik and Mayers 2017 that tepid sponge bath can help to minimize the fever. And take down note that using ice water or alcohol can cause chills, which will produce the opposite desired effect, and instead of decreasing the temperature, it will increase the temperature. And alcohol can cause the skin to be dehydrated or in dehydration. And the last intervention is encourage the patient to increase the oral fluid intake, because according to Gulanik and Mayers, again, the increase of fluid intakes encourage thermoregulation. For our dependent intervention is first administer a paracetamol 300 mg or via IV every 4 to 6 hours as ordered by the physician. As you can see, paracetamol is commonly used medicine that help to treat pain and reduce a high fever according to Adam and Tolwe 2014. Also, paracetamol prevents the prostaglandin synthesis by facilitating heat loss such as sweating, and that sweating can help to minimize the fever. And the last is start an intravenous normal saline solution or solution as indicated by the physician. As you can see, IV is used to refill the loss of fluid via the shivering or chills. And according to Davis and Ogbrew 2019, NaCl can maintain a proper fluid balance and will keep the tissue hydrated. And in addition, sodium is also associated with many processes in the cells, along with muscle contraction, neuron signal transmission, and renal function. And also, the chloride ions are essential to prevent the balance between the acid and the base. And lastly, potassium is a great help for regulating the fluid balance, muscle contraction, and nerve signals. So for the collaborative intervention, it is to monitor the laboratory test such as WBC with differential, because according to Rupert 2015, leukocytosis may indicate the presence and severity of infection. For our evaluation, the same as the first problem, it is quote not done. Due to the pandemic, we are not able to do it in an actual patient, so we put there not done. Now, congratulations, we're on our last problem. Hopefully, you're still listening to me. So, our last problem is dehydration. Like me, I'm so dehydrated from all the talking. But the subjective cue, the patient verbalizes, I defecated 5 times this afternoon. My poop is watery and loose, and I also feel weak. So that's what the patient says. So for our objective cues, the patient has a temperature of 38.9 Celsius, should be 36.5 to 37.7 or 37.5 in some other books. RR is 30, which should be 12 to 20 only. HR is 120 and it should be 60 to 100. The BP is 90/50. And the patient had bowel movement 5 times in a day. It should be only 3. And of course, positive body weakness, positive diaphoresis, and the patient is also positive for water stool and poor skin turgor and oliguria. Because the patient output is only 400 ml per day, it should be 800 to 2000 ml. And for the diagnostic test, The CBC test shows that it is less than 0.001 or less than normal. Also, the neutrophils is less than 0.001 within the normal range. And take down note of this. The sodium is 120. It should be 132 to 142, which is low. The potassium is also low. The potassium level is 2.6, but it should be 3.5 to 5. The chloride is 96, which is low. It's not low. It's um, near the lower normal value, which is 95 to 105. And of course, as always, the patient is positive to COVID tests such as expectorated sputum and endotracheal aspirate. So for our nursing diagnosis is risk for fluid deficit related to increased bowel movements as evidenced by watery stool, frequent bowel movement, urine output of 400 ml per day, sodium of 129, potassium of 2.6, and chloride of 96. Because we chose this as our risk because according to the one study that was conducted in Wuhan, China, 18% of the COVID patient reported of having diarrhea, vomiting, or abdominal pain. So the rationale behind this nursing diagnosis is when the inflammation of the lungs becomes so severe, it can lead to a what? A systemic inflammatory response, which can lead to a septic shock. And because of that, there will be an increase in the capillary permeability in the system, which can cause the fluid to leak in between the interstitial space and accumulation of fluid within the tissue. So it can result to the decrease of the overall volume of the blood and can result in vasodilation, and this can decrease the peripheral resistance and can cause tissue perfusion, which can have a multi-system failure, which can lead to body weakness due to the lack of proper body function, and cyanosis due to poor cardiac output. Also, it is specifically affects the kidney, which would increase the blood urea, nitrogen, and creatinine, which would later cause kidney damage if it keeps producing or the virus keeps producing, and it will affect also the liver, which would increase the liver enzyme, which can cause liver damage. Furthermore, multi-system failure can cause the virus to release toxins to bind to specific enterocytes receptors. Although it is rare in the GTI system, which can then cause diarrhea that would be evidenced by a watery stool and can progress to further process to dehydration that can observe when the patient is having a poor skin turgor, which is in extreme cases. That is according to Sorabi 2020. Now, our knock is hydration. So our short-term goal is after 1 day of nursing intervention, the patient will experience less body weakness and perspiration, will develop good skin turgor, will have 2 to 3 bowel movements, and will have less watery stool and increased urine output of 300 ml per day. The temperature will also decrease to 37.3 from 38.9. The RR will decrease to 25. The RR will decrease to 20, the HR will decrease to 100, the BP will increase to 100/70. And for our long-term goal is after 2 days of nursing intervention, the patient will not experience body weakness and perspiration. The patient will maintain also a good skin turgor. The patient will maintain to have 2 to 3 bowel movements, and the patient will have soft to firm stool consistency. And there is an increased urine output of 800 to 2000 ml a day, and the laboratory values are within the normal values. which the CBC will be 3.4 to 9.6. The neutrophils will be 3,000 to 7,000, and of course the electrolytes values will be in the normal range, such as sodium with being 132 to 142, potassium there 3.5 to 5, chloride to 95 to 100, and of course the patient will be negative to COVID test. So for the NIC is fluid or electrolyte management. So our first independent care is to assess changes in the vital signs, which includes the rising temperature, excessive fever, orthostatic hypotension, and abnormal heart rate. Because according to EJEC 2010, an increase in the temperature or continuous fever raises the metabolism, and through evaporation there is a loss of fluids. So also changes in orthostatic BP and abnormal increased heart rate may suggest a clinical fluid deficit. So next is assessed for the skin turgor, moisture of the mucous membrane, lips and tongue, and indirect indication. This is the indirect indication of fluid adequacy, although the oral mucous membranes can become dry due to the mouth breathing and supplementary of oxygen. Also observe for the I&O, and take down note for the stool and urine color. Do the COCA, consistency, odor, color, and amount, and character, and calculate the fluid balance. So be mindful or insensible losses. So weigh the I&O as indicated, because this will provide us data about the adequacy of the quantity of the fluid volume needs for the replacement. Next is encourage the patient to increase fluid intake to at least 3,000 ml per day or as individually appropriated. So this will meet an essential fluid requirements and reduce the chance of dehydration. And also encourage the patient to take foods such as BRAT. BRAT stands for banana, rice, apple, and tea. According to a website, which is www.webmd.com/children/brat-diet8, BRAT diet can help one to recover from an upset stomach or diarrhea for the following reasons. First, it includes binding foods. Second, the food is low in fiber, which can help the patient to have firmer stool. And banana is very high in potassium, which can help to replace nutrients in the body that was lost because of vomiting or diarrhea. And next is educate the patient about the importance of proper hygiene to avoid occurrence of the disease, because this can reduce the risk for respiratory infection by 16% according to CDC. So for the independent care, assist the physician in the maintenance of 0.3 NaCl 225 cc times 28 cc per hour. According to whom 2016, an insertion and maintenance of central venous line will allow for fluid to diffuse centrally. Excuse me. Also administer IV normal saline solution or electrolytes as indicated by the physician. This is to replenish fluid losses during shivering or chills, or if since the patient had a watery stool. And also fluids are the key to maintaining a hydrated status for the patient. As you can see, an ACL can maintain proper fluid balance and can keep the tissue hydrated. In addition, sodium is active in many processes of the cells such as muscle contraction, neurons, signal transmission, and renal function. And chloride ions are responsible for preserving the balance between acid and base and regulating the fluid balance, muscle contraction, and nerve signal. Next is administer Ursiflora or probiotics 5 milligrams or 2 tablets are indicated or as ordered by the physicians. This is to assist the body's natural gut microbiota. So the potential mechanism of this is to exert the action, which include the production of pathogen inhibitor substances. This is inhibition of pathogen, and it will inhibit the action of microbiota and can stimulate immunoglobulin. And it is can have a trophic effect in the intestinal mucosa according to www.drugs.com. Next is administer paracetamol 300 mg or via IV every 4 to 6 hours as ordered by the physician. Because according to Adam and Tolwe 2014, paracetamol can help to treat pain and reduce and can inhibit the synthesis of prostaglandin. And the last one is to administer medication antivirals such as IFN alpha, liponavir or ritonavir or ribavirin. And it's the same rationale as what I said in problem number 2. So for our collaborative care is to monitor the laboratory tests such as WBC with differential and electrolytes to detect. This is to detect homeostasis or imbalance and can aid in the replacement needs according to Mayo Clinic. So this is the last one. So I hope you're at the very end of what am I talking? Are you even listening to me? So please bear with me. This is the last one. It is the evaluation. Well, of course, it is still coded, not done because we don't have an actual patient.
Recommendations. To further specify on the preventive measures, the World Health Organization recommends that the specific ways to prevent and spreading the virus is to avoid contact with people observing at least 3 feet or 1 meter apart from each other. They need to wash their hands thoroughly as discussed earlier, and this can be compared with a duration like singing the ABCs from start to finish. And not only to properly dispose of soiled items such as tissues that have been sneezed or coughed on, it is important to disinfect whatever people come in contact with frequently, such as doorknobs, utensils, platewares, and cell phones that are constantly having contact with our face and hands. It is also recommended for the community to stay informed and involved. They are to follow instructions given by their local public authority so they can be informed with complete current information. The people can also stay connected and informed through social media and the web. But it is important to know that whatever they search, it needs to be credible sources such as journals, articles, and what they share online should be also valid. It is said that the more the public is educated, the sooner it can make its way towards recovery and have a healthier society.
Summary. To summarize this case presentation, COVID-19 has been newly discovered and it is a virus that infects the body and makes its way to the respiratory system, which gives critical damage to the alveoli cells. This triggers a coughing reflex to expel the foreign invaders, which can lead to inflammation and difficulty breathing in the lungs. Also, since the body signals its immune response to congregate in the infective site, it can lead to alveolar edema or the accumulation of fluid, which can also lead to pneumonia and, worst case scenario, death. And since it is a new virus, it currently has no vaccine, and healthcare professionals are treating the symptoms to alleviate complications. The case presented is a probable patient that is reported to have difficulty in breathing, elevated body temperature, and diarrhea. This patient is provisionally diagnosed with COVID-19
And according to the ABG results, the patient had respiratory alkalosis with a pH of 7.48, an RBC of 0.625, a WBC of less than 0.0001, and a platelet count of 152 by 10 to the third power. And these are all low compared to the normal values. And the chest x-ray findings displayed a small or large patchy shadows with intensive density in both lungs. Lastly, the patient was tested with the RT-PCR test and was confirmed positive of COVID-19. The patient was given collaborative O2 therapy and given NIPPV to treat the difficulty of breathing. The nursing interventions were given alongside of the dependent interventions through routine assessments of the respiratory status and skin integrity, the proper positioning for breathing, the encouragement of fluid and patient teaching, and also antiviral medications were given. The elevated body temperature was treated and paracetamol was administered. Tepid sponge baths were given, and there was an encouragement of fluid intake. Lastly, there was a large fluid loss via diarrhea, and so an IV hydration of 0.3 sodium chloride 225 cc by 28 was administered. Medications were administered, strict I&O observed, and encouragement of diet high in fibers and fluids were recommended and given as patient